Hello, this is Dr. Mike Whitty. I'm the Chief Medical Officer at the California Primary Care Association. I'm also a family physician, primary care physician, and I'm talking today with Dr. Lauren Alving, who represents and directs the California State Alzheimer Center at UC San Francisco, Fresno, and also with Dr. Howie Rosen, who directs the California State Alzheimer Center at UC San Francisco in San Francisco. They both join me today to tell you about the new instrument designed to facilitate diagnosis of dementia in our primary care settings. This is the first in a series of webcasts describing the Assessment of Cognitive Complaints Toolkit for Alzheimer's disease, or abbreviated ACCT-AD. For emphasis, that's the Assessment of Cognitive Complaints Toolkit for Alzheimer's disease. This webcast explains the reasons for using this toolkit. The second webcast explains what it is, what the toolkit is, in more detail. We urge you to look at it after this webinar to get a better understanding of what the toolkit is and what it is supposed to accomplish. Lauren and Howie, why don't you tell us about the reasons that you created this toolkit?
Thanks, Mike. We're really excited to be able to present this instrument today, which we have called, as you mentioned, the Assessment of Cognitive Complaints Toolkit for Alzheimer's disease, or ACCT-AD, as you see on your screen. We've created this toolkit for a couple of reasons. One, our state is facing a growing burden of caring for patients with dementia as our population ages. And two, many of the patients in California and across the country are going without a diagnosis of dementia. And there are several reasons for this, but one of the main ones is that specialty centers such as our own don't have the capacity to evaluate all these patients. So it's very important that primary providers be able to do these assessments. Even if primary providers want to send patients to our centers, the wait is so long that the patients may be waiting months. You may ask, since we don't have a cure and we don't even have disease-modifying treatments at this point, why do we need to look for cognitive symptoms and why do we have to try to diagnose dementia early? Well, ignoring cognitive deficits leads to a bunch of different problems. Patients and their families can be left waiting and wondering for long periods of time about what's causing their complaints. Identification of potentially treatable causes of dementia may be delayed or even missed altogether if no evaluation is done. And patients may lose out on the opportunities to participate in research. We also have to remember that caring for the caregiver and helping them with their emotional burden is part of our job as well. The only way to really address this problem is to facilitate the diagnosis in the primary care setting, so that a complete assessment can proceed as soon as a potential problem or symptom is identified. So why a toolkit? Well, we know that primary providers may feel that they don't have adequate expertise to make a diagnosis of dementia, and they may feel uncomfortable in delivering this difficult news to their patients and their families. However, we feel that this is just like many other forms of medicine, where the diagnosis of dementia can be boiled down to an organized algorithm that can be followed by any experienced and thoughtful practitioner. So we've created a toolkit that gives primary practice providers a workflow that allows them to elicit mild cognitive complaints in their patients, decide whether a cognitive complaint might require an assessment, and pursue that assessment to the point of a diagnosis or a referral. And we provide guidance on when such a referral should be made and what sort of information to provide to the referring physician.
Thank you, Lauren. It does sound like there are important reasons for diagnosing dementia clearly. And it also sounds like having primary care providers elicit memory complaints and have a satisfactory method of evaluating those patients is really important to the best care for them. I'm sure we all know that this takes a lot of time and it can be difficult to do in a busy practice. I can hear right now some of my colleagues saying, well, that's great, but where do I get the time to be able to do this effectively? I'm wondering if you have any data, Howie, about how often this is actually done or why providers do find this difficult to do.
Thanks, Mike. That's a great question. And the Alzheimer's Association has done a lot of work to evaluate that. And it's pretty clear that the cognitive deficits that people are experiencing are not being screened for in primary care settings. They did a recent survey of American seniors, and although almost 95% of them had seen their primary care physician within the last year, only about 47% of them had discussed cognitive issues, and less than 30% had had screening for cognitive complaints. So what that tells us is that they may not bring it up on their own, and whether they do or don't, further formal screening for what to assess that complaint is not being done very commonly. Compared to other screenings, cognitive screening really falls short. So it's not that primary care practices are inattentive to things that need to be assessed. We've gotten very good at screening all kinds of for all kinds of other problems, but cognitive screening is really underutilized. This previous slide talked about the point of view from the perspective of the patient. Here we're looking at things from the perspective of a primary care provider. So despite the fact that these screenings are not occurring, about 90% of primary care providers feel that cognitive assessment is important. So then the question is, if it's not being done, but primary care physicians and practices feel that it's important, why is it not happening? Well, as Lauren mentioned earlier, there are a number of barriers that actually surfaced during this survey, including lack of time, lack of comfort with making the diagnosis, a perceived lack of resources for making the diagnosis and dealing with and helping the patient once the diagnosis is made, and a lack of patient complaints. They may not hear the complaints coming from their patients. What we do know is that patients are waiting for their primary care providers to screen them, and we also know that Medicare has recognized the need, and in order to deal with that, they've added cognitive screening as part of the annual wellness evaluation. So everyone agrees that it's important. It's really just a matter of how to get it done. And as we've discussed, primary care providers are really the key to this, especially as the population of people who are at risk for cognitive impairment grows over time.
Thank you, Howie. It seems clear that most patients are not getting screened, even though patients and providers do feel that this is important. As a primary care provider, I can definitely feel this. I think it's really one of those very important issues that we primary care providers feel a bit clouded about in terms of where it fits into our assessments, in terms of who does the assessment, the screening, from among our clinical team, and how can we actually make that much more effective in terms of the number of people that do get screened, so that it doesn't become another burden for the primary care provider who is trying to stay ahead of his or her schedule. One question then that comes to mind is, how does this toolkit differ from other memory tests that we may use in the mini mental status or the St. Louis University mental status exam or the Montreal cognitive assessment? How will these toolkits improve the statistics that you mentioned just now?
Good question, Mike. There are some statistics that show that even those providers who do use the structured instruments, such as the MOCA that you mentioned, find that they're really insufficient to make the diagnosis. Or these tools are also incorrectly scored or reported in a large number of cases. So basically, what providers really want to know is how to effectively screen for cognitive loss and what to do once that loss is found. So our toolkit addresses these issues. The toolkit supports the primary provider throughout the process of diagnosis. There is an instruction manual and a toolkit providing some several components, including a brief probe for cognitive complaints as well as a full assessment. There's a relatively complete differential diagnosis table, though not necessary to use since we do recommend specialty consultation for anything that is atypical. There are questions to ask patients and family members as well as possible interpretations of the answers given. We also provide scripts to help primary providers with a variety of issues once the diagnosis is made, such as disclosing the diagnosis, driving, and treatment. And lastly, we provide some guidance on billing.
Well, thank you, Howie and Lauren. It's really clear that the reasons that you've developed this toolkit and how it might help us primary care providers in our practices. I'd be really interested in seeing more specifics about the toolkit and how I and my colleagues can use it.
Excellent. As we mentioned earlier, this is part of a series of webinars. The second webinar looks at what the toolkit is in more detail, and we recommend downloading a copy of the toolkit and the instruction manual to have available prior to viewing that webinar. It's available at the California Department of Public Health website that you see on the screen here.
Thank you both again. This has been really very helpful, and we'll look forward to the follow-up webinars to be able to get more specific information about the use of the toolkit. I did actually look at the website that you mentioned on the last slide, and it was very helpful. I do want to say that it's very worthwhile to be able to look at these documents and sort of take them in as to what they can provide you, rather than say, well, this is something else that I need to actually do in my workday, because the amount of information that the toolkit provides you can make the visits that you already have much more efficient and much more effective with this very vulnerable population. So thank you very much.
Thank you.
And thanks very much for allowing us to present this and hosting it with us.